Hello, this is Ana Leon-Arango, Andrew Pham, Randall Rittmann, and Dr. Hassan Ahmed from the Texas Tech University Health Sciences Center Department of Surgery presenting Eroded Gastric Band Causing Acute Pancreatitis. This case began with a 47-year-old female that presented to the emergency department complaining of epigastric abdominal pain, nausea, and anorexia for the past 1 to 2 days. Blood work showed a lipase of 5,964, consistent with a diagnosis of pancreatitis. Other lab findings included elevated liver function tests and normal triglyceride level. On right upper quadrant ultrasound, a fatty liver was visualized, no gallbladder was seen, which was consistent with the patient's history of cholecystectomy, and there was no biliary ductal dilation or choledocholithiasis. The CT revealed a non-obstructive foreign body in the jejunum and a normal-appearing pancreas. The patient had a history of gastric band bariatric surgery in 2009, but the band was no longer around the stomach, and it was deduced that the band had eroded through the stomach and was now the foreign body in the jejunum. Given the patient's lack of gallstones, normal triglyceride levels, denial of alcoholic history, and non-contributory home medications, the common causes of pancreatitis were excluded. Upon further inspection of the CT, a hypodense line was noted extending from the gastric band in the jejunum back through the jejunum and duodenum, compressing the pancreas when passing through the second part of the duodenum and to the subcutaneous location of the gastric band port. An upper GI small bowel follow-through revealed no leak, but delayed gastric emptying was identified. We suspected that was due to eroding of the band through both vagi below the gastroesophageal junction. It also confirmed the gastric band was the foreign body in the jejunum. Since the band and its tubing were still endoluminal, we elected to attempt retrieval of the band endoscopically in the operating room, with the staff ready to proceed surgically if needed. This is a preoperative X-ray obtained on admission showing the location of the gastric band port relative to the gastric band itself. The port was located subcutaneously anterior to the stomach, as is customary. The band was seen in what was, at the time, an unknown location in the intestines, instead of wrapped distally to the gastroesophageal junction. This is a slice of the CT scan done on admission showing the gastric band tubing passing through the second part of the duodenum and compressing the head of the pancreas. So here we can visualize the catheter tubing entering high in the fundus against the stomach wall just proximal to the pylorus. It took several attempts to grasp the tubing, largely due to how taut the tubing was, causing it to erode through the mucosa, which we are able to see here. While the original plan had been to pull the band up retrograde with the tubing, there was too much tension to do this. We imagined this tension was being placed on the pancreas, so the decision was made to cut the tubing externally from the subcutaneous port instead, so the tubing could be released from that anchor. We then proceeded with the attempt to pull everything out endoscopically. Here you can see the tube displaced from the stomach wall and can appreciate the eroded mucosa. This is the first attempt at retrieving the foreign body. Upon removal of the scope, the tubing snapped. Only a small portion of the tubing was left in the esophagus, which was removed. We then went back into the stomach for another attempt. At this point, you can see the tubing in the distal stomach as it passes through the pylorus. While several other attempts were made at retrieving the tubing, this was the final attempt. While we were able to pull it high into the esophagus as in the previous attempts, as the scope was being removed, the tubing snapped again. Only a small portion of the tubing was still grasped, and it was removed. At this point, the decision was made to manage conservatively and see if the patient could defecate the foreign body. On postoperative day 1, the patient's blood work was repeated and found significantly improved liver function tests and a lipase of 261, which falls within normal limits. An upper GI small bowel follow-through was repeated and found the gastric band past the ileocecal valve in the ascending colon, still not causing obstruction. It also demonstrated that there was no leak from the stomach along the path through which the band had eroded. Delayed gastric emptying due to the band eroding through the 2 vagi was again seen. On the evening of postoperative day 3, the patient successfully passed the catheter and gastric tube. The following morning, an abdominal X-ray was obtained to verify the passage of the entirety of the foreign body. The X-ray findings confirmed this belief and the patient was discharged. On follow-up, the patient did not endorse any symptoms of gastroparesis. We are reporting a case of effective endoscopic management of an erosion of a gastric band through the stomach causing acute pancreatitis. This appears to be the first case reported in which the gastric band was both in the jejunum and still attached to its port by the catheter tubing. This also appears to be the first case reported in which pancreatitis was caused by the catheter tubing compressing the pancreas instead of by the tubing obstructing the common bile duct. Thank you for watching our presentation.